Welcome to Psychiatry, Child and Adolescent Psychiatry Edition. Today is Monday, March 31st, 2025. I am your host, Dr. O'Leary, a Child and Adolescent Psychiatry Fellow in the National Capital Region. This is a podcast I designed to help myself and other Child and Adolescent Psychiatry Fellows study for their boards. But anyone interested in human development and mental health will get something out of this. I'm using AI to assist me with the content creation. The tool that I used to create this episode allows me to feed it papers that I found during a literature search of peer-reviewed and reputable sources. Then I create a prompt to guide the discussion. I usually have to create 2 or 3 different prompts, explore the output of each, fact-check it, then pick the best parts, edit out the problem parts, and paste it all together. Even though I'm using AI, all of the content in this podcast should be considered to be my own opinion and no one else's. At the very least, it is compiled by me and then released to you, so I take editorial responsibility for that. If you find errors in the content or have suggestions for improvement, I would love it if you could go to psychiatry.com and fill out a form there to let me know. You can also email me at feedback@psychiatry.com. That's PSYDACTIC.com. Today's episode covers major depressive disorder in children and adolescents. According to the American Board of Psychiatry and Neurology, content related to depressive disorders will constitute 7 to 9% of our board exams, so it's worth a first, second, third, and even fourth look. So let me leave you in the competent hands of my AI co-hosts, Algernon and Alisa, or Allen and Alberta. They don't care what you call them. Just call them maybe.
We're tackling a pretty heavy but really important topic. Depression in, well, kids and teens.
Yeah, youth, mental health, it's a big one. A lot of folks are trying to make sense of it all.
It is, and that's what we're hoping to do today. Cut through the noise, really distill what matters most. And let's be real, this isn't just a small segment of the population we're talking about.
No, not at all. And the thing is, when depression in young people, kids and teens, goes unaddressed, the repercussions, well, they can be devastating.
Absolutely. You're talking about a higher chance of depression popping up again in adulthood, a greater risk of developing other mental health issues, and of course, the most heartbreaking consequence of all.
Yeah, the increased risk of suicidal thoughts, suicide attempts, and, well, tragically, suicide completion. It's a harsh reality, suicide being the second leading cause of death for those aged 10 to 19. And, for young people with existing psychiatric conditions or those who've attempted suicide before, that risk, it skyrockets.
It's a stark reminder of why this is such a critical issue to address. So today in our deep dive, we're laser focused on extracting the most vital information, the real nuts and bolts of how depression is diagnosed in kids and teens, what treatments have the official FDA stamp of approval, and how important therapy is, both on its own and in conjunction with medication. We've poured over systematic reviews, clinical practice guidelines, a whole bunch of research studies, basically to bring you the essential knowledge without, bogging you down with too much information.
Right.
So first things first, diagnosis. What's the prevalence of depression among young people? Give us the lay of the land.
Okay, so when we talk about major depressive disorder, or MDD, we see that about 2% of children experience it. Now, in adolescents, that rate, it jumps up significantly, between 4% and 8%.
Wow, that's a big jump.
Yeah, it is.
I would just like to hop in here and point out that there are a lot of different numbers talking about the prevalence of depression in children and adolescents, and it seems to depend a lot on how you define depression, what cutoff you use, even where you do your study. So take these numbers with a grain of salt, although they are generally accurate in terms of their magnitude and directions of change.
Now, another interesting thing is that during childhood, the ratio of boys to girls who experience MDD is pretty even, like 1 to 1.
Okay.
But once puberty hits, there's a shift. It becomes more like 1 boy for every 2 girls.
Huh, that's fascinating. Why do you think that is?
It really suggests that there's this complex interplay between, well, hormonal changes that happen during puberty and the societal pressures, especially on girls, that could contribute to the development of depression. And another thing, we've even seen MDD in preschoolers.
Really? That young?
Yep, although those episodes might not always meet the full 2-week duration that the DSM-5 requires for a diagnosis.
Okay, that makes sense. So what about the overall picture? As kids grow up, head towards adulthood, what are the numbers like then?
By the time they reach 18, about 20% of young people in community samples have experienced MDD. It's a pretty substantial portion of the population. And it's not just those who get a full MDD diagnosis. There's this other group, about 5% to 10% of kids and teens who experience what we call subsyndromal symptoms.
Subsyndromal, so they're not quite meeting the full criteria for MDD, but they're still struggling.
Yeah, exactly. They're experiencing some symptoms, maybe not enough for a full diagnosis, but they're having a tough time, socially, academically, all that.
So it's still a big deal.
Oh, absolutely. And they're more likely to have a family history of depression, a higher risk of attempting suicide, and they're more likely to eventually develop full-blown MDD. It's like a warning sign.
Got it. So for those who do meet the criteria for a full MDD diagnosis, what exactly are clinicians looking for? Like, what are those core symptoms based on the DSM-5?
Okay, so the DSM-5 lays out specific criteria. For an MDD diagnosis, someone needs at least 5 of these symptoms during the same 2-week period. And a really, really important point, one of those symptoms has to be either a depressed mood or a major loss of interest or pleasure in most activities.
Makes sense.
Now, the tricky thing with kids and teens is that depressed mood doesn't always look like, classic sadness. It can actually show up as, irritability.
Oh, interesting. So a kid who's suddenly more irritable than usual, that could be a red flag.
Definitely. And along with that persistent sad or irritable mood and lack of interest, other symptoms we look for are, significant changes in weight or appetite.
Yeah.
For kids who are still growing, it might be a failure to gain weight as expected.
Got it. What else?
Sleep disturbances. We're talking about insomnia, trouble falling asleep or staying asleep, or the opposite, sleeping too much, like hypersomnia. And that's happening almost every day. There might also be something called psychomotor agitation, meaning they're restless, fidgety, can't sit still, or psychomotor retardation, which is the opposite. They're moving and talking much slower than usual. These are things other people would notice.
So it's not just what they're feeling internally, it's also about changes in their behavior that are visible.
Exactly. And then there's fatigue, just feeling wiped out all the time, lack of energy, and feelings of worthlessness, guilt, like way more than is warranted.
Heavy stuff.
It is. And then there's trouble concentrating, thinking clearly, making decisions, that kind of thing. And of course, recurrent thoughts of death. This can range from fleeting thoughts to, very specific plans or even attempts.
And these symptoms, they can't be explained by something else going on, right?
Right. The DSM-5 is clear about that. The symptoms can't be due to, say, substance use or another medical condition. And this is key. Those symptoms have to be causing real problems in the young person's life, like their relationships, their schoolwork, just their ability to function day to day. It's about the impact, not just the symptoms themselves.
So once a clinician has identified these signs and symptoms, what happens next? How do they assess the situation and figure out what needs to be done?
Well, a comprehensive assessment is crucial. It's not enough to just check off the symptoms. You need to understand the whole picture, right? You need to assess the severity of the depression. Is there any suicidal ideation or thoughts of harming others? Are there any signs of psychosis? Is substance use a factor? How agitated are they?
So many factors to consider.
Yeah, and you also need to look at things like how likely are they to actually follow through with treatment? Do their parents have any mental health conditions? And what's the family environment like?
It's really about understanding the context.
Exactly. This helps decide the intensity and the setting for care. Do they need outpatient therapy and medication? Or is it more serious, requiring inpatient hospitalization? We're also seeing these collaborative care models emerging, where mental health professionals work directly with primary care physicians. It's like having a mental health specialist right there in the family doctor's office.
Oh, I see. So it's more accessible, less stigma.
Exactly. Now, in terms of measuring success, we're looking for what we call treatment response.
Treatment response, so basically, is the treatment working?
Yeah. It usually means either the young person no longer meets the criteria for MDD, or there's been a significant reduction in their symptoms, like a 50% or greater decrease.
Okay, so a noticeable improvement.
Right. But even with a 50% reduction, they might still have some lingering symptoms. So some clinicians aim for a score of 28 or lower on the Children's Depression Rating Scale Revised, or CDR-SR, along with improved functioning for at least 2 weeks, sustained improvement.
And are there other tools they use to gauge progress?
Yeah, they might use standardized scales like the CDR-SR. There's also the Clinical Global Impression Scale, specifically the Improvement Subscale,
Mhm.
or CGI-I. It gives an overall rating of how much the person has improved.
So it's about looking at both the specific symptoms and the overall impact on their life.
Right. Clinicians also need to assess other things throughout treatment.
Yeah, definitely. If someone is on medication, it's super important to check if they're actually taking it as prescribed, if
Mm.
they're having any side effects, and what they and their parents or guardians believe about the benefits and risks of the medication.
Yeah, those beliefs can really affect whether someone sticks with treatment.
Absolutely. And it's really, really important to assess for any history of suicidal thoughts, homicidal ideation, or physical symptoms before starting any medication.
Okay, why is that?
Well, it helps to differentiate between what was already there, potential side effects, and if their mood actually gets worse or they develop new problems while they're on the medication.
That makes sense. So it's about having that baseline to compare to.
Now, let's talk about those initial steps in managing depression. What happens right after that diagnosis and assessment?
Psychoeducation. That's the first step, and it's super important, both for the young person and their family. It's about explaining in clear terms what might be causing the depression, what those specific symptoms are, what the usual course of the illness looks like, and what the treatment options are. We talk about the risks and benefits of each approach.
So, knowledge is power.
Absolutely. And involving parents and sometimes even teachers as partners in treatment, it's crucial.
And research has shown that doing this psychoeducation can actually make people more likely to stick with their treatment and might even help to reduce symptoms on its own.
That's great.
Yeah, and if a parent has depression themselves, psychoeducation can be especially helpful because it helps them get better at solving problems related to their illness and dealing with any behavioral or attitude challenges that their kids might have. Giving them things to read and pointing them to good online resources can really help reinforce what you talk about, too.
That sounds very helpful.
Now, let's delve into those treatment approaches. What are the main options?
Well, the most common initial approach, especially for kids and teens, is actually psychotherapy on its own.
Really? Even more so than medication?
Yeah, yeah.
Yeah.
And there's a lot of different types of therapy, but cognitive behavioral therapy, or CBT, and interpersonal therapy, or IPT, have the most research backing them up, especially for adolescents.
Okay, CBT and IPT, I think most people have heard of those, but maybe not everyone understands what they actually involve. Can you give us a quick rundown?
Sure. So CBT is all about identifying and challenging those negative thought patterns and behaviors that are feeding the depression.
So it's about recognizing those unhelpful thoughts and learning to reframe them.
Exactly. And then there's IPT, which focuses on relationships and social skills. The idea is that improving those areas can really impact someone's mood.
Interesting. So one is more about thoughts and the other is more about relationships.
Yeah, you could say that. And it's not always clear cut which one is better. One study actually found IPT to be more effective than CBT, but then another study by the same researchers found the opposite.
Wow, so it really depends on the individual.
Yeah, it does.
And one of the things that our sources really emphasize is that family dynamics are really important too.
Yeah, that makes sense.
Attachment-based family therapy has been shown to be more effective than just general supportive clinical management.
That's good to know. And it seems like IPT has a particular focus, right?
Yeah, IPT is really effective for adolescents with moderate to severe depression and for older teens. One of its main focuses is on addressing problems between parents and children, which is often a big factor in the depression.
What's great about IPT is that it seems to be easier to adapt to different settings, like school-based clinics.
That's good news. Making therapy more accessible is so important. Now let's shift gears and talk about medication. Specifically, what about pharmacological treatment, using medication to address depression?
All right, so medications, particularly a class called selective serotonin reuptake inhibitors, or SSRIs, have been shown to improve both the symptoms of depression and overall functioning in adolescents and children with MDD. And there are actually two specific SSRIs that are FDA approved for use in young people.
So they've gone through the rigorous testing and approval process specifically for this age group.
Right, so fluoxetine, which you might know as Prozac, that's approved for children 8 and older.
Okay.
And then there's escitalopram, or Lexapro.
Here he means escitalopram or Lexapro.
It's approved for adolescents ages 12 to 17.
So two options specifically for younger people. That's good to know. What does the research tell us about how effective they are?
Well, studies have shown that fluoxetine, even when used by itself, can lead to real improvement in depressive symptoms in adolescents with MDD. And when it's combined with CBT, it might even help prevent future episodes of depression.
Interesting. So medication plus therapy. We'll get to that in a bit.
But
What about escitalopram?
has also been shown to improve both the core symptoms of depression and overall functioning in adolescents with MDD.
It's encouraging to know there are these options, and they've been studied specifically in younger people, but I think a lot of people, understandably, have concerns about the potential risks of SSRIs, especially for kids and teens. What does the research say about that?
Yeah, that's a really important question, and it's something we always need to consider carefully. The research does indicate that there's a potential for increased risk of serious side effects in young people taking SSRIs, and they're also more likely to have withdrawal symptoms if they stop taking the medication suddenly.
So careful monitoring and gradual tapering are essential.
Absolutely. And there's also been some concern about paroxetine, another SSRI, potentially being linked to a higher risk of suicidal thoughts or behaviors in adolescents with MDD compared to other SSRIs.
That's definitely something to be aware of.
And looking at the data as a whole, there does seem to be a slightly higher risk of suicidal thoughts and behaviors, although not always statistically significant, across all SSRIs in this age group. The FDA has issued warnings about this, so it's not something to take lightly. This is why it's absolutely vital to have close monitoring by a doctor when a young person is on any SSRI.
Absolutely. Benefits and risks need to be weighed carefully, and regular check-ins with the doctor are essential. Now, let's talk about that combined approach you mentioned earlier. What about using both medication and psychotherapy together? What's the evidence there?
Well, there's really compelling evidence that combining fluoxetine with CBT can lead to greater improvement in depressive symptoms in adolescents with MDD. And studies have also shown that CBT plus medication could be associated with lower rates of relapse, both in adolescents and children, compared to using either treatment alone. There's this landmark study called the Treatment for Adolescents with Depression Study, or TADS. TADS found that combining fluoxetine and CBT led to much bigger improvements in clinician-rated depression, more kids achieving remission, and better overall functioning compared to CBT alone, fluoxetine alone, or even a placebo.
So the combination was clearly the most effective.
Yeah, and not only that, they also found that the combined treatment led to a faster response, meaning symptoms started improving sooner.
That's huge, especially when you're talking about something as serious as depression.
Right. Combining medication and therapy isn't just adding one thing on top of another. It's like they work together to create a much stronger effect.
Oh, okay. So what happens if a young person doesn't respond to the initial treatment? Like, what if they've tried therapy or medication alone and it's just not working?
That's when we start thinking about what we call treatment-resistant depression. There are some strategies we can try. It's important to remember, though, that these haven't been studied as extensively in young people as those first-line treatments.
Got it. So what are some of those strategies?
Well, we might try optimizing the medication, making sure they're on the right dose and have been on it long enough to see if it works. We might add CBT or IPT if they haven't already tried that.
Makes sense.
We could also switch to a different antidepressant or even add another medication to boost the effects of the first one.
Some examples of these add-on medications are bupropion, lithium, T3, or thyroxine, T4, and in some cases, a second-generation antipsychotic medication.
So there are a lot of different options to try. And I guess the decision about which one to use really depends on the individual person, right?
Yeah, exactly. Optimization and augmentation, where you're basically trying to make the current treatment work better, are usually considered if there's been some response, even if it's not a complete remission, so a partial response.
Okay.
But switching meds is usually what you do if there's been little to no improvement or if the side effects are too much for them to handle.
Makes sense.
But it's important to say that even though these are common things that clinicians do, there haven't been a ton of studies looking specifically at how well and how safe these strategies are in kids and teens with MDD. So it's about being flexible and adjusting the treatment plan based on how the person is responding.
Exactly.
Okay. And what about after someone starts feeling better, like their depression is in remission? What happens then?
To prevent relapse, we usually recommend that they continue treatment, whether that's with SSRIs, psychotherapy, or both, for at least 6 to 12 months after they've recovered from that initial episode.
So even though they're feeling better, it's important to keep those supports in place.
Yeah. And if someone has had a really severe episode, or if their depression keeps coming back, they might need to stay on maintenance treatment for a year or even longer. Finally, our sources touched on some things that might affect how well a particular treatment works for someone. They call these moderators of treatment effects. And what did they find out about this?
Yeah, a few things seem to be important. For example, in one study, having a lower family income, more severe depression symptoms at the beginning of treatment, and having ADHD all seem to make CBT less effective compared to fluoxetine.
Interesting.
Other things, like having a history of trauma, having multiple mental health conditions at the same time, and a higher level of hopelessness reported by the young person, might also affect treatment outcomes. But the researchers who did this review really emphasized that we need more research to understand how all these different characteristics of the person might affect how well different treatments work.
That makes sense.
Yeah, and if we understand that better, it can help us to personalize treatments more, giving the right treatment to the right person based on their unique situation. As we wrap up, are there any other key takeaways from the research that we should keep in mind?
Yeah, I think there are a few important things to highlight. First off, we have a lot more research on treating depression in adolescents than we do for younger children.
So more work to be done there.
Definitely. And the research we do have, well, it can be pretty varied. Different study designs, different types of therapy or medication, different groups of kids being studied. It makes it hard to compare the results sometimes.
That makes sense.
And we also have to remember the difference between statistical significance and clinical significance. Just because a study shows a statistically significant improvement, it doesn't always mean that it's a real meaningful change for that young person's life. Like, can they go back to school, hang out with friends, do the things they enjoy?
Right. It's about actual practical improvement.
Exactly. And to make things even more complicated, a lot of those psychotherapy studies, they don't always report on potential harms or side effects in the same way that medication trials do.
That's a good point. It's important to have a full picture.
And finally, we just need more research. More studies on how to help younger kids, on depression subtypes other than MDD, on the long-term effects of different treatments, on comparing different therapies head-to-head.
Always more to learn.
Always. We also need to figure out what constitutes a clinically meaningful change, like how much improvement is enough for a young person to feel better and function well. And we need more research on how to tailor treatments, like what works best for which kid based on their individual situation.
Those are all crucial points. It highlights how much we're still learning and evolving in this field. Okay, last but definitely not least, how should treatment decisions be made for a young person struggling with depression?
It always needs to be a shared decision. The young person, their family, and the clinician all working together. It's about combining the best available evidence with what the young person wants, what their family feels comfortable with, and what fits their unique situation.
I love that. It's not a one-size-fits-all approach.
Absolutely not.
So to wrap up this incredibly informative deep dive, let's do a quick recap. We've covered how common depression is, the key criteria for diagnosis, and why a comprehensive assessment is so important. We've talked about the main treatment approaches: psychotherapy, like CBT and IPT, and medication, especially those FDA-approved SSRIs, fluoxetine for kids 8 and up, and escitalopram for teens 12 to 17.
Right.
We've also highlighted that combining medication and therapy can be super effective, especially for more severe cases and for preventing relapse. But it's crucial to remember those potential risks associated with SSRIs and the importance of careful monitoring.
Absolutely. And one last thing, it's crucial to remember that this is complex. Every young person is different, and their treatment needs to be tailored to their individual circumstances.
Couldn't agree more. All right, as we close, I want to leave you with something to think about. Imagine the possibilities if we could identify depression early on and provide integrated mental health support in places like schools and primary care settings. What could that mean for young people who are struggling or at risk? What systemic changes would really move the needle and ensure that everyone has access to the care they need when they need it?
Yeah, what could we achieve if mental health was truly woven into the fabric of our communities?
Exactly. Thanks for joining us for this deep dive.
Yeah, thanks everyone.
Nothing in this podcast should be considered personal, medical, or mental health advice.